Good day, and thank you very much for joining us from all over the world with different time zones for this roundtable discussion organized by the International Center for Professional Development in Armenia on COVID-19 with Dr. James Merlino, Chief Clinical Transformation Officer in Cleveland Clinic. My name is Rafi Avitsin, and I am a professor of anesthesiology in the Department of General Anesthesiology in Cleveland Clinic. But today I have my president of ICPD hat on to moderate this roundtable. The International Center for Professional Development in Armenia is created with the goal of providing resources to continuously improve knowledge and experience in the field of healthcare for practitioners, healthcare professionals, and biomedical technology experts. ICPD has organized a series of education resources, nowadays mostly towards COVID-19. One of them is today's roundtable. We have invited Dr. James Merlino for Cleveland Clinic Health System. Cleveland Clinic, as many of you know, is one of the top hospitals in the United States of America, recognized year after year by US News and Health Report magazine. During the current COVID outbreak, advanced planning, workforce redeployment, clinical team-based approach, and strict adherence to personal protective equipment with specific goal-directed resource utilization were the important components that led to a successful control of the pandemic in this mega health system. First, I want to introduce the other participants in the session. Some of them are the leaders of the hospitals in Armenia that are dedicated to controlling the pandemic in this country. First and foremost, Deputy Minister of Health in Armenia, Ms. Lena Nanushian. From Arabgir Medical Center, Dr. Arab Abloyan, who's the CEO and the scientific director, Dr. Ashot Sarkisian, who's the medical director of pediatric department in Arabgir, as well as the university chairman of pediatric department and advisor to Ministry of Health in Nephrology, Dr. Lilit Vartanian, head of the emergencies department, and Dr. Stella Sarkisian, who is the head of COVID department. From Surpastavata Mair Hospital, Dr. Georg Simonian, who's the director of COVID program and the director of National Burn Center, Dr. Haik Antonian, medical director of infectious branch and chief of anesthesia and ICU emergency services. From Surp Grigor Lusavoric Hospital, there is Dr. Anna Martirosyan, who's the deputy director of medical center, and Dr. Sarkis Ghazarian, who's the director of COVID program. And from Nork Infectious Control Hospital, Dr. Meher Davidians, who's the director of infectious disease, and Doctors Naira Stepanian and Temine Galanchin, who are infectious disease specialists. Before turning to Dr. Merlino, I would like to invite Deputy Minister of Health, Ms. Lena Nanushian, to deliver her message on behalf of the Minister of Health. Dear Lena, if you want to unmute, we will listen to your message.
Okay, thank you, colleagues. Good day. I would be very short, just to welcome all participants and stress few points from the point of view of Minister of Health in Armenia. As you know, the COVID-19 pandemic already claimed the lives of more than 500,000 of people and is challenging our societies, requires increased international cooperation and global solidarity. So it's a reminder of how crucial cooperation without borders are to our collective health, prosperity, and security. In Armenia, as you know already, we have more than 30,000 cases registered, of which about 20,000 are recovered, but sad to say that we have more than 500 deaths, and death rate is 1.7%. The COVID-19 pandemic today is overwhelming hospital emergency response system in every country, including in Armenia. So specific challenges facing hospital medicine is that we must learn to respond to this rapidly changing environment in which critical decisions should be made within hours and days, but at the same time, we need to plan increased clinical needs over the coming months and to count the possibility of burnout and concerns about staff well-being also. So currently we're learning day by day from our doctors, from our partners around the world, and we have this type of calls starting from January and February, and definitely without these connections we will not be able to organize effective response in our country. So we also agree that we need to learn all the lessons from collective management of current health crisis to take the necessary measures to strengthen the health architecture and ensure that the countries are better prepared for the next pandemic or next wave. So I would like to welcome all of you and to express my sincere thanks to all colleagues who worked hard to organize this meeting, but I would like to thank ICPD for the opportunities that you are bringing, Dr. Avedisyan, to Armenia to help us in this emerging situation. I'm sure that the experience presented by Dr. Merlino will be valuable for improving hospital management in our country. So once more, thank to all organizers, and I'm sure we will have very interesting discussions on this issue, how to better and more effective response COVID-19 pandemic in Armenia. Thank you.
Thank you, Ms. Nanushian, for your message. I'm hoping this cooperation will improve outcome for everyone, and it's a two-way street in here. Well, next is Dr. James Merlino, Chief Clinical Transformation Officer in Cleveland Clinic. I would like to invite him to start his presentation, and after which we are going to have opportunity to hear some of the questions from our panelists. Keep in mind this webinar, this roundtable is being recorded, and it will be available again online in both languages, Armenian and English. So for those of you who have not been able to participate, or those who have some technical difficulties, no problem at all. We're going to have this available very soon. So, Dr. Merlino, if you want to unmute and start your presentation, you can share your screen.
Thank you, Dr. Avedisyan. Let me move to share my screen. First of all, thank you very much for having me on this conference today with all of you, such a distinguished group of physicians and scientists from Armenia and other places. I heard it multiple times from many of you in preparation for this, as well as just recently from your deputy minister, that we are all in this together and we must learn from each other. What I wanted to do today is present a high-level overview of some of the things that we focused on at Cleveland Clinic to help us manage through the pandemic, which, as all of you know, is very much still with us. And I think that clearly until we have a treatment, a cure, or a vaccine, we all have to adopt the new normal of living with COVID and figuring out how to do that as safely as we can. I believe, and I think we at the Cleveland Clinic, as well as many of you, I'm sure believe as well, that we can do this, we can do it safely, we can protect our people, we can protect our patients, we can take care of people, but we have to be vigilant, and we have to share. There's no one that has the best knowledge on this. I think we all learn from each other. And one of the things that Cleveland Clinic has greatly benefited from is our worldwide presence with facilities around the world. I think this event, if there's any good in this pandemic, and there's not much, it has brought us together better as an organization, as a culture, which is something we're very proud of. I thought it would be just right to share a high-level overview of Cleveland Clinic. Our vision is to become the best place to receive care anywhere and the best place to work in healthcare. It's aspirational. There are amazing places to work in healthcare and receive care all over the world, but our CEO and our leadership team believes that we have to keep pushing ourselves to be better. We have about 67,000 caregivers across the world. We see about 10 million total visits a year with 308,000 hospital admissions. We have 4,500 employed physicians and scientists with an equal number of private physicians who use our facilities, and we have nearly 200 trainees in various programs. As I mentioned, we are proud of our international footprint. This is a picture of our hospital in Abu Dhabi in partnership with Mubadala Healthcare. It's been very successful for us, and we're delighted and honored to be able to bring the Cleveland Clinic model of care to that part of the world, and it's been a tremendous experience for our caregivers. Unquestionably, I think our task in the best of times, but clearly also in the management of COVID, is to deliver safe, high-quality care, be patient-centric, continue to do what's important, which is evolve our culture, control costs, and provide access to people that need it. We very much take this integrated view that safety, quality, and patient centricity or patient experience are the big three. We prioritize safety first. We can be the best clinicians practicing in the best medical center in the history of medicine. But if we do something that harms a patient, then all of that best means nothing. We have to focus on safety. We believe that the platform is high reliability, where we focus on processes and culture, and ultimately integrating human factors in an environment where we challenge people to continuously improve. So from a safety, quality, and patient centricity perspective, that is very much our model and how we think about things. Certainly COVID has challenged us in ways that I don't think any of us could ever have imagined in our careers. I made a joke recently with some of my colleagues where I asked them to raise their hand if they took the How to Manage a Global Pandemic course in college. Nobody did, obviously. And very much we're making this up as we go along. We're trying to interpret the data as best we can. We're trying to learn from each other as best we can. I think that on average we've done pretty well, but it's obviously an evolutionary process. I think something that we've learned, and I alluded to it earlier, that this has brought us together as an organization much tighter. We realize that in healthcare, we're all in this together because it's one of the only industries where we all need healthcare, and the things that we do for our patients, likewise, are things we do to support our families and friends and ourselves. But COVID doesn't discriminate. It affects everyone across the world, and more than ever, we are in this together, particularly, as said earlier, as healthcare professionals, as we come together to learn how to fight this disease. I have to just call out our CEO, Dr. Tom Mahalovic. He has been an inspiration during this crisis. He's an amazing leader and individual and physician. But from the very beginning, as we started to see the clouds of COVID coming towards us, he said our number one priority is going to be to protect our people. We are going to be transparent in our work. We're going to share. We're going to support our community. It's not about Cleveland Clinic patients. It's about taking care of anybody around us and anyone, anywhere that needs it. And he has been a steady and consistent, calm voice in the pandemic, telling people that we will get through this, we will be fine. And in a leadership team that's been stressed beyond recognition, as most of you know from your own personal experiences, having a strong, calm, reassuring voice at the top is critical to our success for managing this global pandemic. So things that we did, and I'm speaking at a high level, and I'm glad to go into more detail with questions, but I want to give people a perspective. We were an organization that's highly patient-centric, and we really shifted to being caregiver-centric. True to Tom's early words in the pandemic, we recognized that if we could not keep our people safe, we were not going to be able to keep our patients or families safe. We couldn't care for patients. One of the biggest risks that we all shared in healthcare was the concern that our healthcare workers would contact COVID and it would take them out of the care of patients. So we needed to do everything we could very early to focus exclusively on making sure that we were giving our people the supplies that they need and caring for them in ways that could support them through the crisis. Key to managing the COVID crisis in our state of Ohio in the United States was having good data. We immediately shifted the entire organization towards managing COVID. I like to use the analogy that we stirred the ship in the winds of COVID. All of our data and analytic resources were put on understanding what the disease was. We were receiving updates daily on where we thought the trends were headed in our state, in our region, in our country, and also across the world. We believe that having insight into this early and monitoring it every day during the crisis helped us to better plan the resources that we needed or we thought we would need to take care of this global pandemic. So really understanding the modeling, and there were many, and we were looking at all of them to try and make sense of what was going on. Some of them were better than others, but we used all of the models, all of the data that we could get our hands on to really try and understand and predict where we were headed. And this is a slide early in our journey at the end of March, and the red line indicates our caseload in Northeast Ohio. And what we found ultimately was that that was about 2 weeks after the governor of our state shut the state down and enacted maximal social distancing. And ultimately that red line followed the orange line for about 40-80 social distancing, which was a very short peak for the initial phase of the pandemic. But having good data was critical. We had a team of individuals across the enterprise with representatives for every site across the world, focused exclusively on personal protective equipment and how we use it. Starting with modeling out exactly how much PPE was being used for various situations in caring for patients. That team also worked on how they could ration PPE, how we could reuse it, how we could sterilize it and reprocess it, and also work on how we could acquire more. Who would have thought that one of the scarce resources that we would be dealing with in healthcare are simple things like masks and face shields, but they become treasured commodities as we sought to manage this. But key to managing it successfully was really modeling out how much you have, how much you're using, figuring out ways to use it more effectively, and then projecting how much time you have before you start to run low on supplies, before you could get resupplied. So that occupied a lot of our time and a lot of effort. We very much adopted the Swiss cheese model. For those of you that haven't heard this before, this is critical for safety science in the airlines and healthcare and in the military and nuclear power. And basically it talks about preventing harm to individuals. So industries that have events that can harm employees or customers or patients, think in a safety science that you constantly have errors shooting at you and your job is to prevent them. And the Swiss cheese model talks about various things you can put in place to protect your people, and that each process or each technology or each culture intervention is a piece of Swiss cheese. Nothing is perfect. Everything has holes in it, but when you can line them up together with multiple things that make sense, you get a better barrier to prevent errors. And that's exactly how we have done it for our organization and how we've talked about it to our partners in the community. As I'm sure many of you have experienced, there's a lot of skepticism in what works to prevent people from getting COVID versus what doesn't work. And we're very upfront and transparent in saying nothing is perfect, but when you line them up together and people are vigilant and we enforce things like cloth masks and social distancing and hand washing, we can create a barrier to protect people the best we can. And this model has been very successful for us to educate our staff, our employees, on how to think about protecting themselves and their patients. And we've also used this model in helping to work with organizations outside of Cleveland Clinic who are working to try and reactivate. We've been very successful in protecting our caregivers. This is an early chart ending in April, showing our infectivity rate for caregivers of our 65,000 people. We've had about less than 1% infected with COVID. That is a rate that's lower than community infectivity. And what we've also been able to show through contact tracing and careful analysis is that we do not have a caregiver yet that was infected with COVID that was taking care of a COVID positive patient. We're very proud of that, and we think it speaks to the safety precautions that we've put in place, the diligence with which we follow up on it, and the ask of our people to follow the rules to protect themselves and to protect our patients. We hope to continue that trend, and we are extremely vigilant about monitoring our use of PPE and also making sure that our caregivers are doing everything they need to be doing to protect themselves. At the start of the pandemic, we started monitoring serious safety event reporting. This is something that we do across the system every single day, where we ask our caregivers to report things that could harm patients or harm other caregivers. We started segmenting out those events early in the pandemic so that we could monitor just COVID-related events. And you can see that we had a significant decline from the beginning of the pandemic as the pandemic progressed to its most severe point. This is very important for several reasons. Number one, it shows that our caregivers feel safe to report when there's something they're concerned about. Number two, it shows that the processes that we've put in place are working, because as the pandemic worsened and our case volume increased, we were seeing less reporting of errors. And that's a good sign, because we believe that, again, demonstrates that what we were doing was working, and that our caregivers were feeling safer as we got into the pandemic. The other thing that we did very early on, which I don't think is unique, but we're very proud of, is that safety and quality metrics that we would review once a month, we started reviewing twice a week. And the idea behind this is twofold. Number one, we wanted to be able to detect through signals anything that could be awry with the pandemic. So anything that we thought we would be seeing that we should be concerned about, new things that the pandemic would bring us, we wanted to be very cautious of observing. The other thing that we wanted to do is that we wanted to make sure that we were monitoring the care we were delivering for non-COVID patients. As our teams retooled to work on managing the pandemic, we wanted to ensure that we were able to provide the same safe, high quality care to other patients that needed it without causing any errors. What's interesting is that we did not see any significant degradation in our safety and quality performance. However, something that we did see was, and we continue to see it, was increase in medical VTE, venous thromboembolism disease, and increased mortality. These two changes are directly related to COVID patients. And as I think we all know from recent evidence that's come out, that there are thrombovascular events that happen in patients that are affected with COVID. And in some cases, in some series, the early mortality of COVID positive patients, particularly in elderly and minority patients, was high. So we were seeing this in our signal detection as we were monitoring it twice a week. But other metrics that we follow were either the same, stable, and in some cases decreasing, such as our serious safety event reporting, which I thought was a very positive outcome as well. We communicated aggressively to all of our staff. We looked at every single thing that touched COVID patients and COVID specimen processing. This is one example of a sign that was created that goes on all of our specimen delivery systems, our tube systems, so that people were being extra careful about managing their COVID specimens. And again, I think it speaks to the diligence with which we applied our knowledge and our teams to everything that touched COVID. So we have signs across the organization talking about social distancing, talking about hand washing, talking about mask usage. Again, looking at every touch point where any caregiver or any patient could be affected. We tried to make sure that we were addressing it with education so that people would stay aware of what was going on. And lastly, this is just a scientific slide of the COVID virus. We received scientific updates from our scientists nearly twice a week, ensuring that our leadership team could have the best available information that they were able to glean from work that was being done around the world. Because we felt that really continuing to pay special attention to how the virus was evolving, the epidemiology of the virus, how the treatments were evolving, was essential to informing our ability to understand how to take care of patients and also protect our people. So just to review some key activities, increased safety and quality surveillance across our organization. We executed caregiver support programs to manage burnout, to provide food service to caregivers' homes who were taking care of COVID patients. We contracted hotel rooms close to the hospital so that caregivers on the front lines would not need to travel home, or if they felt unsafe, going back to their families. I mentioned the programs that we put in place to monitor our caregivers who were infected. We carefully managed COVID risk One of our biggest areas of concern was and continues to be caregivers getting too comfortable. Once people get very comfortable with a process, they can make errors, and we wanted to make sure that we had people be mindful. We wanted to put tools in place so that we could connect families with patients in the hospital. We stopped visiting hours during the height of the pandemic, one of the hardest decisions that we made, but we wanted to use digital means to keep patients connected with their families. And we tried to constantly look at ways to improve what we were doing and really had people adopt this mindset of what else could we be doing differently. We learned how to communicate better across the organization and communicate more frequently. As Rafi will indicate, we just got our engagement survey back from the organization, and we got extremely high remarks for how we were communicating. We worked better together with our competitors and others in the community. We were having conversations with organizations, our competitors that we never talked to, on how we can coordinate care. We accelerated some of our strategic focus areas, such as virtual health. Prior to the pandemic, we were doing 3,000 virtual visits a month. In the month of May, we did 200,000. We learned how to innovate by doing different things to take care of patients. We worked differently. We asked physicians to do jobs that were different to them. We asked physicians who were not working in the pandemic to be retrained on how to be ICU docs and how to help the ICU teams take care of critically ill patients. And we found new opportunities by helping our partners and businesses and other organizations in the community to reactivate their businesses as the pandemic wore on. I just want to close with a quote from one of our former presidents: in crisis, be aware of the danger, but recognize the opportunities, and we have to be optimistic as we work to live successfully and safely in this new era of COVID. Thank you very much for the opportunity to participate, and I will now take questions.
Thank you very much, Dr. Merlino. A fantastic presentation, and I'm pretty sure everyone did learn a lot. That some of the questions came up, and I just want to reiterate what you said about opportunity, and hopefully this roundtable will also be taken as an opportunity to learn, to engage, and to have more communications in future for this, as well as other medical problems and healthcare problems. I am going to open up for questions for the panelists. There is a couple of questions I have already received and I would like to discuss, and it would go online with some of the things that you have said until if anyone has a question, they can unmute and go ahead. But let me ask this question first, and I got this question from Ridge Medical Center, St. Gregory the Enlightener. And the question was about the model of triage being used in a system that has different hospitals. Where do you take the patients? Do all of them go to the same center? How would you know where to send the patient in these situations?
Is that for me, Rafi?
Yes, yes.
It's a very important question, and when you're facing an incredibly high volume of patients where you anticipate that your capacity is going to need to increase, in our case 3 or 4 times what we have, what we decided to do was designate a couple of our hospitals in the system as hospitals that would be focused on taking care of COVID patients. During the pandemic, the government suspended the rules that normally prohibit you from transferring patients to different hospitals. So it allowed us to really designate hospitals that could be focused on taking care of COVID patients. This did a couple things. Number one, it allowed the teams taking care of the COVID patients to get very comfortable with the processes and to share the learnings in the microenvironment. The other thing that we were able to do in our larger hospitals in other regions is we designated units to be COVID units. And again, the same thing applied where you were able to have teams of people that were focused exclusively on taking care of COVID patients. And this provided 2 benefits. Number one, it kept them safer because they were more familiar and practiced in the precautions. And number 2, it was better care for patients because they were learning faster and sharing that information, that learning on how to take care of those patients, such as things like proning ICU patients, et cetera.
Thank you. Another question before I turn over is about caregiver, physician, as well as nurses and other healthcare workers burnout. I say this because I do know, even within the participants of this panel, there are people who for weeks have not seen their family, gone back home because they're so much dedicated in the hospital that is subspecialized in COVID. If you could, Jim, if you could tell us a couple of ways that the clinic has thought, well, I know it because I'm there, but if you can share some of the ways that the clinic has addressed the burnout, as well as how to take care of our caregivers in this time, that would be great.
It is also a very important question, and I think it's something that we will not know the full effect of until probably a year or two after this pandemic is over. It is also something that is top of mind for our leadership, and we have a team that is exclusively focused on caregiver support. The things that we have done are, number one, to figure out everything we could possibly bring to our caregivers to give them the support that they needed. So we talked about, for instance, lodging close to the hospital so they didn't have to travel home. So if they wanted to stay away from their families, if they were concerned about their families, if people needed support at home, we provided food service delivery. We tried to arrange childcare. So anything we could do to support them in this work and also in their personal life was very important. We also made the decision early on that a lot of organizations, healthcare organizations across the United States, have been laying people off. They've been cutting salaries. We said from the very beginning that we will not do that. We're not going to ask our people to be on the front lines of this pandemic, putting their personal safety at risk, and then having to go home and worry about supporting their families. So we tried to do everything we could think of to just lean in to support our people and let them know that we were behind them. And I think the other thing that's really important that I touched on in my presentation is we need to be super focused on safety for our caregivers. If there's something that we should be doing that's new, that can protect them, we should be doing it. Because the last thing we want is our people to believe that we're not looking out for them. And I think that's been something that's been very successful for us.
Yes, and that's how the statistics that you presented shows that our caregivers, they're safer inside the hospital than outside, because their infection rate is lower, and even the ones that have or the ones that did not get in contact with with COVID patients. Now let's hear from other panelists. Any of you, if you have any questions, if you have any comment, Dr. Pavloyan, if you want to comment on this, especially in the hospital, in your hospital with pediatric patients, please go ahead.
You know, first of all, I want to thank Professor Merlino for very, very interesting and fruitful presentation. And of course, your experience will help us for choose useful lessons from your experience and to use in our future activities. And then I like very much one term you used. This is a continuous improvement. Really, I can say from our experience, COVID forced us to learn every day and then to apply fresh experience for next days. This is a very interesting situation. And I'm sure, and in your hospital also, you feel this thing, because it was everything new for us. And then, of course, another very important thing, Arabkir, we are working mostly with children, because it is a pediatric hospital and it is a reference center for children. But they come in our hospital with mothers, and mothers, they 80–90%, they are with COVID, and then also they have a problem. And here we have our colleagues with whom we work every day, and we keep contact, and then we maybe our doctors, they call Dr. Gazarian Sarkis 3-4 times per week, to Dr. Haik Antonian, to Meher Davidjan. They are work together. It is a network of collaboration. And then it's new type of work, and you understand you cannot work alone. You cannot do even in one hospital this work. You have to collaborate with others. Maybe our colleagues, they can present their feeling and their experience also. This is my feeling in these few months. Thank you.
Thank you, Dr. Pavlian. There is a question. Anyone in here has any questions? Because I have questions coming even from YouTube. That's on how to deal with PCR negative but CT positive patients. It's mostly a clinical question, but this goes on, as far as I know, on their patients under investigation. But if anyone from people who are present can answer that. Anna Martirosyan, do you want to answer that question? You're on mute.
I'm sorry, can you repeat the question?
Rafi,
You're on mute.
Unmute.
Sorry. Patients who are PCR negative but CT positive. If you have high suspicion, what do you do with them?
It's a different question, sure, because we have such kind of cases, sure. Sure we have, but it's important to have both positive and test and that, but sure, first we see if the PCR is positive, and after that we see the clinical, how is the clinic for patient, yes, and sure we start to manage the patient. It's important because only to have a PCR positive test is sure important and the first point. But after that, sure, we are doing manage and doing all the who is necessary to do. The first is CT, sure, CT scan.
Yeah, but as it's obvious, there's a lot of those who could be false negative. So anyway, that patient is getting isolated and being worked up more to answer that question. Anyone else, any questions on the panelists? One of the questions I have to the panelists, and any one of you can jump in, is how do you do the triaging of patients? How do they know? I mean, obviously, I know that the pediatric patient will go to the Arab Care Health Center, but how do you decide on the overflow? Which medical center a patient goes to when they are found to be positive?
Rafi?
Dr. Davidzians, please.
Yes. First of all, Dr. James, thank you very much for your very nice and detailed presentation. As a director of the center, which is responsible for the triage of the main patients in Armenia, because there are two hospitals. First is North Infection Clinical Hospital, and the second is National Burn Center. So what we do, most of the patients come to the hospital through emergency, like ambulance, and there are concrete criteria for the hospitalization of the patients. According to the order of the Minister of Health. So we have the order of Minister of Health, how to manage the management of the patients with COVID-19. And we decide whom to hospitalize and whom to just to check and send to the outpatient clinic. In case of hospitalization of the patients, so we take a smear from throat and from nose for PCR testing, just in the admission unit in the hospital, and we hospitalize them. We do chest X-ray or CT scan, it depends on the condition of the patient, and we start the treatment of the patient. After the test result, when it is positive, so we call to the special center, which is called triage center, and they decide to where to transfer patient from our hospital to another hospital.
Rafi, you're on mute.
Sorry about that. I just don't want to have extra noise there. Thank you for the answer. Now, Dr. Merlino, one other question about increasing the capacity, how they can use other resources to provide beds just in case we have more. And I'm saying that because I think Dr. Babloyan can say that they added a wing within a few days, which was, for Armenian standards, it's a big deal. And I know that in Cleveland Clinic, we also were able to modify the learning center, the newly developed university, into a place that we can accept patients. How else can we increase the resources that we have, both as far as beds as well as other resources?
You know, it's interesting to learn how creative you can be when you're facing a crisis. And I remember back in March, we were literally thinking that our capacity for nursing beds was going to need to increase 5 times what we had, and our ICU capacity to increase 3 times. And when you're thinking, and literally, I mean, that's what we believed. And so I think that we, like others as well, and I'd be interested to hear how you've done it in Armenia, we looked for places that made sense. So as Rafi mentioned, we have a health education campus, and we were able to literally in the course of 3 weeks design it to hold 3,000 patients. We put oxygen lines in, we put beds in, we put electrical in. It was an amazing transformation. Thank God we never needed to use it. But we were talking about making that a low risk hospital where people on 3 liters or less with COVID would be there. We talked about making ICU rooms out of operating rooms, intensive care unit rooms out of post anesthesia care unit rooms. I mean, it really became an issue of looking at your footprint and deciding, what type of patient you could put where, and anything outside of a regular nursing unit bed that had capability for oxygen and suction and monitoring became a ICU bed. And to the comment about triage, we basically came up with a triage system where we would triage the severity of COVID patients into various different rooms. So the most severe would be in the ICUs, the less severe would walk back into converted ICU rooms, and then the least severe that required hospitalization would go into the beds that we created in the health education campus. I think you just have to be creative and learn how to stretch resources. And again, it's a testament to our culture, as I'm sure others around the world and other healthcare systems as well, just learning to do things to take care of people. It's amazing how you can learn quickly. And to Dr. Babloyan's point about continuously thinking about ways to do things differently. I've never seen it like this before. It's amazing.
Yes, Dr. Sarkisian can tell us about what happened in Arab Peer Medical Center as well, or Dr. Bablayan, it doesn't matter.
Maybe I will start. You know, I'm not personally much involved in organizational problems, more in medical. But what I would like to stress very much that the number of beds and the capacity is very important, but it should be very much done in time, on time. So having only few patients in our department, Arab Peer decided to introduce departments dedicated already, having even no patients over there. And also these prefabricated models that we put over there. And this led to the situation that we would never have stopped, and the work is going on and going on. So I think we are very much lucky, because we had a big expert in disastrous situations, Arab Bablan, starting from earthquake and so forth. So this all should be done on time, and this has been done at Arab.
I think that was a success story for that hospital. And I want to come back to what Dr. Merlino said about resources as well. And you have to figure out what resources you have and elaborate on that. It doesn't matter how big of an hospital healthcare situation, how much cash money that hospital healthcare situation has. It's about the innovation. It's about the thought process of what to do with what you have to have the best response. Dr. Bablayan, you have your hand raised if you want to go ahead.
I'm sorry, I forget to tell our colleagues, if somebody has difficulties for language, English, like me, you can present a question or answer in Armenian, and Rafi will help us to translate in English. But be open. You can speak Armenian if better to explain. This is the thing. Then, okay, please continue.
And Dr. Merlino, Armenian is good. They can testify that. We have a question, actually a couple of questions. The Deputy Minister Anushan has a question. Please go ahead and unmute yourself.
Thank you, Dr. Merlino. Thanks for the interesting presentation. I have one question connected with the job mixing you have mentioned when you engaged other specialists into ICU treatment. So now we're also doing the same process, and we are now in a stage of preparation of educational program for such doctors that will be engaged in ICU department. So I would like to know your experience, which specialists you think or you have engaged in this process, and how you will advise us to move forward on this direction or not. Thank you.
Thank you for your question. The process, we didn't ask specific physicians to participate. We asked any physician to participate. Our belief was that you know, if you were a physician, you had the capability to be able to do some of these tasks. I think what really worked well, and Rafi, you may be able to comment, because I think anesthesia was a big part of it. What we did was we created teams of physicians that then worked with an expert. So for instance, you could have 10 physicians working under an intensivist, so that essentially you're using the other physicians to extend the work of the intensivist. Same thing for the hospitalists who were focused on taking care of the COVID patients. You know, we had groups of physicians underneath the expert so that they could extend them. And that's how they were organized. And then we put the physicians, for instance, the ones that were helping to support the ICU docs or the anesthesiologists through kind of, I don't want to oversimplify it, but, you know, ICU 101 to give people the basic skills. Rafi, do you want to comment? I believe you guys were involved in it.
Yes, actually, I can also be helpful on that question. The system that worked well in Cologne Clinic is the team, as well as a team of teams. There are certain medical expertise needed, for example, airway management, and you direct those who are expert in that to take care of that. So for example, we had airway teams, which are anesthesiologists and nurse anesthetists, and those who are involved, that their job would be to fulfill the intubation, extubation, airway changes and things like that. There are obviously other levels of physician as far as how far they are on an ICU. For example, an infectious disease person has their point of view just to that because that's what they need. But someone who's, for example, radiation oncologist has a different way of approach, and they are the ones who need a little bit more of an education to remember what they learned during the medical school for ICU management. And then as Dr. Merlino said, there is a top intensivist doctor, which under that goes the different levels of physicians which can do what they do. And a surgeon will be very, very good in changing lines, for example, and that is how the team would utilize that person. Now, the same thing goes for education as well. I'm a program director of a subspecialty of neuroanesthesiologists. What we got from graduate medical education is to announce which of the trainees or residents, interns or whatever could be redeployed on something that's both safe for them as well as they can work better there rather than the specialty that they are learning. So it all comes to needs as well as this team of the intensivists at the top and according to your specialty working together. There is another question from Facebook Live about airflow of all ventilation in the hospital. And I don't think that this is true, but we don't have HEPA filters on all our ventilators, do we, Dr. Merlino? That's not going to be even possible. Yep. So we answered Dr. Azayan about PCR negative and CT positive. Any other questions about I did get another question in here. What should be done to make a healthcare center, which is declared a COVID-19 center, also accept subspecialty patient population? And this is probably the portion to open up to the reopening and accepting patients which are not COVID or are COVID and have a specific urgent surgical process needed. How do we approach that, Dr. Merlino? How are we going to reopen for other patients which are there? One important thing is we have noticed that the diagnosis of cancer has come down, which is not because there's no cancer, because they're not coming to be evaluated, and we're worried for later on that they're going to come with a higher stages of cancer.
Yeah, well, first of all, I think as we've reactivated, we've continued to cohort our COVID patients, both into hospitals focused on COVID and also units. So trying to keep them as isolated as possible. The second thing is letting people know it's safe. We just did a survey of patients, and what we found is the biggest thing not getting people back to healthcare is they're worried about getting COVID in the hospital. And I think what we've learned, what we've all learned, is probably the safest places in the hospital because of the measures that we put in place to protect our caregivers and protect our patients. So we're segmenting, we're cohorting COVID patients into COVID units, COVID hospitals. We're reinforcing the message that it's safe to come back, and we're continuing to keep the restrictions in place that we put in place during the pandemic. So visiting hours are greatly restricted. We temperature check everybody entering a facility. We require people to wear masks. We require people to sanitize their hands when they come in. So we're keeping the measures that we learned to protect people during COVID in place as we reactivate. Rafi, you're muted.
Sorry again. So any other question about reactivation on the capacity that you guys are opening the hospitals and which surgeries are being done? If anyone has any comments. Dr.
Activation of select elective procedures. I'm wondering whether you restarted your transplant programs in your Cleveland, because we stopped it, and this is, and we don't know when we can and may restart it.
We never really stopped it. As you know, transplant is a little bit opportunistic, and when you have an organ available, you have to use it. And so well, I guess we stopped it, Rafi, for a little bit.
Very short.
But generally we kept it going. And obviously transplant is a double-edged sword, because you can't not take advantage of an organ, and at the same time the patients are so compromised. So we tried to be as careful as possible. We test transplant patients. We were testing transplant patients. We were trying to keep them in a bubble. It was very difficult.
You know, we're leaving donor transplantation, so we are able to stop it and plan it further on. So what your suggestions when we can start, which indicators we should use to understand where we can,
we did. Yeah, go ahead, Rafi.
Even the planned ones, you really need to catch the best time. If you wait a long time on a patient that really needs it, you may not have the best result afterwards. So I think in a center which is planned the transplant, you really have to go case by case, both as far as the recipient as well as the hospital in general. Do you have places or not? Are you going to use a lot of resources and a lot of other patients are going to die or not? So it's a case by case process, I think.
Yeah.
Dr. Bablingan, go ahead.
About transplant, of course, Ashut, I think with our strict regulation, internal regulation of our hospital, I think we can restart our transplant program. We're ready already to restart. We're ready, in my opinion. Another thing, even I can tell you, organizational thing, also very important. We stopped all air conditions and ventilations. But now we we start to reconstruct our system to give each room separate flow, not to melange flows, and to give each room separate flow. It's cost, but it's help, because in Armenia it's hot weather, and then we have to think about also, because summertime it's sometimes not possible to work because of this temperature, high temperature. Yeah.
So we have just 2 more minutes to end our roundtable. Just want to thank everyone again, and we can listen to one last question. Just want to remind everyone that we are going to have a COVID conference July 25th, which is again going to be free. We invite everyone to join, and the speakers are going to be from mainly United States and Armenia, and it's going to be in English and Armenian, and needs registration, and the information are on the Facebook and Twitter and everything from ICPD.am. Any more questions? I just want to take the opportunity one more time and thank you, Dr. Merlino. I hope this will not be the last time that we see you virtually in Armenia. I hope it will be other opportunities that we will have you join us. We can go to Armenia. I'm telling you, it is a wonderful place, very, very hospitable people, and we will have more collaborations, cooperations.
I look forward to it. Thank you for the opportunity to participate.
Thank you very much, and goodbye.
Goodbye.
Good. Thank you.